So this is not meant to be a technical talk about AI and large language models. I hope to give you a 30,000-foot discussion about where we are in medical education, because it's very early, and where we hope to go, and provide some data along the way, some from our group and some from others. So the objectives include examining first, I think it's something we all have to think about, how the use of technology and now AI may be affecting our brains. And then analyze the practical considerations of how AI may impact our skill development in medicine and describe use cases for large language models. And the hope is augmenting our current structure of medical education. And we're going to provide some examples that my team is researching in critical care, and how these use cases could serve as examples for other areas that we really want to encourage more medical education research. So as I said, I don't want to spend too much time walking through the AI details, but I want to provide the definitions that the AAMC provides, and they have really nice web resources about artificial intelligence in medical education. So AI refers to a broad range of advanced techniques and processes that perform complex tasks such as large language models, machine learning, and natural language processing. And I'm going to talk about different large language models. There are AI models trained on vast amounts of text data capable of generating human-like text. Excuse me. There was an interesting, actually a nice paper last year in JAMA from Howell and colleagues. And I'm not going to walk through all the epochs in history of AI, but started in the 1950s. And now we're really at a different time, that AI 3.0 foundational models. You may have heard the term generative AI because it generates new content, performs different types of tasks without new data or retraining. And so basically, you prompt and you create new model behaviors. So that's what's very exciting and different about this time. Does anyone know who this is? Yeah, go ahead. You're on it. You're on it. Yes. Geoffrey Hinton. So this is very, very good. I'm very impressed because I didn't know until I started doing some research a couple of years back about this. So he's a computer scientist. He's a cognitive scientist known for his work on artificial neural networks. And he is known as the godfather of AI. And he won the Nobel Prize in Physics in 2024 related to machine learning and his work. But he said, as you put it, his quote in 2016 was that people should stop training radiologists now. So obviously he's much smarter than me, but I just want to point out there are going to be lots of hot takes and predictions, but 10 years later almost now, that is not a good take, right? And again, someone who knows the field better than anybody. So now I'll point out, there is no other specialty more than radiology that's involved with AI products. The FDA has approved over 700 FDA-approved AI models in radiology. And so you would say, well, is that just taking away radiology? Well, that's not true. There are more spots. There are 1,208 positions this year for diagnostic radiology residency positions, and the average salary of a radiologist is higher than ever. So 10 years later, I can't predict the duration of our careers, but I'm hoping before everyone in this room retires, we'll still have a job. So I want to point that out as we think about this. But I also want to point out that the way we do our jobs will likely be very different. And so this was an image, and now I give these talks, I'm starting to make images with ChatGPT or Gemini. And so this is a Gemini image, as opposed to I used to spend a lot of time making my own images and making them super nice for the PowerPoints. And so, excuse me, so there's a term called general purpose technology. And so I want to explain that a bit. But when we went from, well, back before our time, the horse and buggy to the steam engine, and then we went to electrification, and then we went to the big change of the internet. These were all what we call general purpose technologies. I think an economist coined that term. And not only did they make an incremental improvement to our workflow, they changed how we work, right? So I suspect that this is going to be the same as true of AI. It's a general purpose technology that will change the way all of us work. And so in the field of medicine and medical education, it's going to be true for us as well. I think that's part of why Dr. Hinton made that prediction. But I think there's a difference between what the future may hold and implementation, which is often quite messy, right? So my goal here is we, as leaders in medical education and in medicine, should study and use technology carefully so that those of us who lead in these areas can thoughtfully shape that future and improve our students' training and benefit our patients rather than having Silicon Valley shape it in their own vision, right? I think that because that is happening as we speak. So I'm going to discuss use cases that I've always looked at and say, we're not doing this well already in medicine and medical education, and can we leverage AI to improve our current status quo? And so there's another paper that was quite a provocative manuscript in the Chronicles of Higher Education. It's called "Are You Ready for the AI University?" I don't know if anyone has read that one. So it's actually a little depressing. People say, yeah, everyone will lose their job and academia will be totally disrupted. And it has a lot of strong predictions. And again, I think you have to be careful. And that's why I started with that slide. You have to be careful about predicting the future and the timing of change. I want to highlight here, though, a passage that discusses a hopeful view and I think an opportunity for us. You can see here, when we talk about AI, it will develop the best practices in a discipline as a means for better understanding educational approaches that yield better student outcomes, such as retention, degree progress, and graduation. And so the goal would be for AI to undertake a process of continuous learning and improvement to ensure a personalized student experience. So, for years, we've talked about we need to personalize medical education. We need to find the specific gaps in knowledge and skills of learners, identify them, and then implement kind of the exemplar best practices of educational programs and do this broadly. But as humans, we just don't have the scale and ability like AI to process reams of data, do this efficiently, and hopefully augment medical education to scale our best practices. So, and again, the status quo, this is our status quo, right? We have a traditional approach to education, and it's clearly suboptimal. And so I think there's an opportunity to improve it. The traditional way we teach, whether it's a topic in the preclinical portion of medical school or on clinical rotations or on residency and fellowship, where there's occasional time for teaching and lectures, you've got a fixed amount of time for the education and to complete that program. And then obviously, if there's a fixed amount of time, at the end of that time, each learner will have variable percentages of your program goals met. And so the question that is raised, and you hear it now all the time, in each of our fields of medicine, there are certain skills that every learner should achieve mastery of, so they can do it safely on day one unsupervised. Now, later in this talk, I'm going to talk about our teams working mechanical ventilation, and that was an area where I was interested in because at the end of the day, that's the one thing in critical care. I can't call anybody and ask an answer. I'm supposed to be the final answer, right? So that's an example of a complex technical skill, but that's foundational to my subspecialty practice. But in all of our specialties and subspecialties, there are things like that. So, and clearly society would expect us to have mastery of those things, and not as you develop, but when you're taking care of that person's loved one, the expectation is after training is completed, you have expertise in that foundational skill. And so this is a recent New England Journal paper. It's been nice. There's been several medical education papers in the journal this year. And it talks about the transition to competency-based medical education that is happening. And the x-axis here is developmental progression over time, and the y-axis is stage of development. And so you can see that some trainees will take longer than others to develop competence in individual skills. And one trainee may pick one thing up faster, and it might take them longer to pick up something else. But at the end of the day, as people who lead programs, we need all of us to be capable physicians. So the question is, if we have somebody that work here, you see it. So that trainee on the right, trainee number 3, who may need a little bit more time, can we leverage tools like AI for precision medical education to advance learner development even after the traditional course or rotation is over? That will be a great advance over our status quo for current and future physicians. And so as we think about that and we think about what use cases we might implement, I want to take a step back and talk about, before we can augment our intelligence medicine, we want to talk about this important emerging challenge. there are profound changes that are happening now in the way our learners and future learners are consuming and composing content. And I think it's highly relevant as we think about how we structure education in the future. So take a sidebar to point some of these things out. So this is data from the U.S. National Assessment of Educational Programs. It's looking at reading patterns of teenagers over the last 40 years. And as further context, do you see where those two curves, so the more turquoise blue hardly ever read is going way up, and then almost every day read, the darker blue is going down? Where do those curves intersect? What year is that? It was 2007. What did you say before that? Sorry. You're all over this. So that's right. The iPhone was released in 2007, and that is when those curves intersect. So you can see that in the smartphone era, our learners aren't really reading books. And there's lots of manuscripts about that, about kids going to college, never read an entire book in their life. A shift has occurred now to short form content, more reliance on YouTube, TikTok. These are preferred now. And so my worry is that when we talk about things that are hard in medicine, that we need you to deeply focus and think through and frankly struggle to learn complex concepts. That's more challenging as we're in more of a short form content era, right? And then one of the other things that I found, it's not just your screens at home. Schools have shifted, right? And there's also data that that's bad. So we all know that anyone who has kids, you have Chromebooks and iPads and a lot of curricula are on there now. And there's emerging data that more screen time in the school, not even considering what they do at home with YouTube and TikTok and so forth, is associated with worse test performance. So you can see here, this is a program for international student assessment. And so this is an international, as it's titled, test given to 15-year-olds in 90 countries. And so as you see, since these tools were introduced into classrooms, this is since the 2012 onward, if you spend more than an hour of time on your screen during the day, you see how scores are plummeting. So there's clearly an association there. And so now there are papers that are coming out to reinforce this. This was just published in 2025, earlier this year. This is Nguyen and colleagues did the largest systematic review and meta-analysis of nearly 100,000 participants in 71 studies. And they found increased short form video use was associated with poor cognition. And then you break down that further in the next slide, I'll show you all the different domains of cognition. And then they also looked at mental health. The effect size was smaller than with cognition, but increased short form video was associated with poor mental health and stress and anxiety showing with the highest association. So here are the cognitive domain data. There's a forest plot depicting effect sizes, and you can see here the circles in individual papers, the effect size, and the lines to the right and the left are the 95% confidence interval. Anything to the left of 0 means a negative impact of short form video. Anything to the right of 0, which you don't see anything, is a positive impact of short form video. And so what we see in every domain, you can see overall attention, that open diamond. You see overall inhibitory control, overall language, overall reasoning and working memory. And then the sum of all those cognitive mean effect size. It is all negative in terms of the input of the effect of short form video on cognitive correlates. So there's lots of things that are changing the way we consume content, changing the way our brains work. So now we're getting to the last couple of years use of ChatGPT and other large language models. Has anyone read this paper? That's the first 4 words of the title, Your Brain on ChatGPT? Yeah, you read that too? That's great. So this is we'll have you give the second half of the talk. So this is a preprint, and a lot of what I found is talking to colleagues when they in industry and Google and stuff, they don't bother actually submitting it to peer review. They just want to do their paper and move on to the next paper. So that's a bit frustrating, but it is what it is. So you're going to see lots of preprints in this area. But there's lots of, so now we talked about the iPhone social media area and the effect on consumption. But now we're saying, hey, it's a lot faster to write something if we use a large language model. So what is the effect on our brain? And so this was a really interesting study by MIT labs, right? This is they examine the cognitive costs of using large language models in the educational context of writing an essay. So these were and so I also used Gemini 3 to make this slide. I input the study, and this is the figure they put out. So again, I'm always interested. I throw things in them and I see what it comes out. Sometimes good, sometimes it's crazy. So it's a good learning experience and an experiment for me. But what you see here is, so these were over the course of several months. There were 3 groups. They randomized 18 people to use just your brain to write at least a 2,000-word essay, and you write 3 essays over several months. Then one group was allowed to use Google, and then one group used ChatGPT. And then they studied them after doing the 3 essays. And let's see what they found. And so what they did is they looked at multiple domains to study brain function and essay quality. They used EEG to measure brain activity, to assess cognitive engagement when they were going back through the essays, natural language processing to assess the linguistic and topic consistency. And then they had humans score the quality of the essays, and then that was confirmed with an AI scorer as well. And so the group that used their brain only, those 18 participants, had the highest EEG activity and most widespread connectivity. And the ones that relied on the large language models had the weakest brain connectivity, suggesting that the reliance on these tools associated with lower cognitive activity. One of the really interesting parts of this paper, though, is then after the 3 essays, they crossed people over. So they'd been using their brain only for the last several months. Then they said, you can go ahead and use ChatGPT. Again, these numbers are small, N is 9. And then the LLM group said, okay, now you have to write just with your brain. You can't rely on an LLM or Google or anything. And so the group on the right, the LLM to brain group, after that 4th essay, showed lower alpha and beta wave brain connectivity, suggesting lower engagement, even after the AI use was removed. And so it suggests a carryover effect of prolonged AI use. The brain to LLM group for the 4th essay demonstrated stronger memory recall, more active EEG. So the conclusions of the MIT authors was that repeated LLM use led to not just consistent, but persistent underperformance in neural activity, language quality, and writing behavior. And so it is a very interesting world. And I think Dan told you about my prior role as an editor for a journal. Lots more papers are going to be written by AI, and then people are going to start reviewing them with AI. We're going to be in a very odd meta world where people aren't in the loop, and there are cognitive effects of all this. And that's what I want to point out as we think about the future of medical education. And so I think the question that's come up, which I'm actually happy is coming up now, is we need to have this conversation. Are we entering an era of lost deep thinking? And so, so there's an article in the New York Times asking this, and they're talking more to parents of kids in school now. Your job has changed in the AI era. And so, and it talks about the current environment negatively impacting how our students learn. And I'm going to highlight a quote because it's something I say, so it's confirming my biases. So, but you see here where it says, but when it comes to learning, the acts of thinking and struggling are what foster critical thinking skills. Brains, like bodies, developed as they're used. So I think that is a conversation we need to have. And it's something we've talked about as educators for a long time. This is the famous Yerkes-Dodson curve from a 1973 paper on stress and optimal performance. And you probably heard that common educational axiom, learning occurs at the edge of your comfort zone. And that's where this comes from, right? You want to have some stress, and you want to have the optimum amount of stress, not to the exhaustion and cognitive overload, but you need to have some stress to optimize your performance. And then, so what happens? Part of the learning is in that struggle. And so when we're taking away the struggle, what's going to happen to learning? And that's an open question now. And it's something that, again, I think as I'm going to talk about some of these use cases and areas of study, this has to be in the front of our mind as we think about that. So then again, let's take all this, from theory and to the bedside, right? When I think about what we do in medicine, much of it relates to deep thinking, but you have to do it in a high stakes clinical environment, right? And when it relates to complex concepts that make up the foundational skills of all of what we do, such as physiology, pathology, immunity, there's so many complicated things. But then when we get to these high stakes situations where you can see on the left, a patient in the ICU on a ventilator multiple drips, hemodynamic invasive monitoring, on renal replacement. And when they decompensate, you have to be able to rely on those foundational knowledge and skills that you have to take care of them. And similarly, on the right, in the trauma bay, there are multiple people having to resuscitate a patient and do their own single technical skill in a high cognitive load situation. So again, as we think about it, with the loss of deep learning, how is it going to affect us in medicine? And so as we think about that, I want to talk through, again, the second half of this talk is more the opportunities we have. And so I want to think about these risks and be very open and honest about that, but we also have to think about the benefits. And so let's walk through. So this was a figure from a paper by Raja Abdel Noor and colleagues. He's the new editor. They have a new New England Journal spinoff, New England Journal Clinician. But this is part of the New England Journal Medical Education series with AI. And so he put this figure out into two parts. The left side, which I've cut off, and I'll show you the right side in a moment, is prior to ChatGPT being introduced. The x-axis is time. The y-axis is the performance in a given skill, right? So pre-AI, the authors make the point that the framework they're describing, that through practicing critical thinking, some learners, we eventually get to the point of expertise or proficiency as we finish training, right? And so the people who are excellent, who are the outliers, the master clinicians at certain things, they're able to have what they call adaptive practice, where you learn things. This patient you see is different from what you learned, but you're able to apply that to this patient and provide the best care. There's also lots of evidence that as physicians and clinicians, we do a lot of, in different skills, automatic practice. We do the same thing over and over and over again. And there are studies of this, of making the same errors on reading EKGs and so forth. We go back to what we learned, and it may be right and it might be wrong. And so there's an opportunity. Can we get each of us in a continuous learning cycle to get to adaptive practice? So now let's think about the world today. And when I think about undergraduate medical education, at the bottom there, novice, they are learning only in a world where they have access to large language models. Now, maybe a fellow in the room has gone through medical school in a pre-ChatGPT era. So they've learned some things here on the left side of the screen, but they're going to learn the rest of their training on the right side. And then as faculty, we've done all our training prior to ChatGPT. So there are risks, and I want to point them out, but now I also want to focus on the opportunities, right? So I think for everyone, the concern of over-relying on a large language model will mean we could de-skill, meaning skills we've already learned, we will lose them. And I'll show you an example in a subsequent slide. But also for our youngest learners, they may never skill. They may just rely on the LLM and not learn skills that are fundamental to their future practice. So, but I do want to focus on these areas in the boxes that I highlight. We don't do that well in focusing on adaptive practice in medical education. How can we find exemplar ways to really bend that curve and really use AI? That's an opportunity now, because pre-AI, we aren't doing this consistently, to have AI enhance adaptive practice. So before I get into some of those use cases, I want to talk about a paper that just came out that was one of the first examples of de-skilling. So this is a recent paper that published this year in Lancet GI and Hepatology, and this is a practical example of physicians de-skilling. So this was a study in Poland in 4 endoscopy centers, and they used something called the adenoma detection rate. I'm not a gastroenterologist, but to evaluate the quality of colonoscopy. And so they had experienced GI doctors do colonoscopies, and they looked at their adenoma detection rate. Then they use an AI tool to help them with sort of subtle mucosal abnormalities that their eye may have missed, and to increase adenoma detection rate. Well, an interesting part of this study, 3 months after they introduced the AI tool, they took it away on certain days, and then they checked their adenoma detection rate. And so what did they find? There was a 6% decrease in adenoma detection rate when you took the tool away. And so compared to when they'd never had the tool. So, the hope is you never lose a tool. It's always there. But again, it is something you worry. If this is a foundational skill of what you do, this short exposure has caused de-skilling. So again, it's something we all have to think about in whatever we do. So I want to, again, present a balanced view of this, but there are several use cases for AI and mechanical ventilation. And I want to, the opportunity to get more assessments. How do we tailor your learning if we don't assess you? And then get personalized feedback from those assessments. And then provide self-directed learning resources and automate that. Also, as educators, instead of just looking at an in-training exam once a year, getting insights into gaps in knowledge and skills so we can act upon them and do that in a thoughtful and methodical way. And then for each of us, I think what would be was our aspiration was we'll each have our own education portfolio, and we can take that from the undergraduate medical education to medical education to GME to CME and keep track of the things we've done well and not, and then also have resources to keep brushing up on those things we didn't do well. So I want to talk about some use cases and areas that we've studied. And I want to start with something very simple, right? Multiple choice questions. And so first I want to step back in how we got to this use case. So as Dan mentioned, our group in pulmonary and critical care, we have the largest regional network. All of our fellows, 57 now across the DMV, Baltimore and DC, all go and take part in a summer and winter education block. And so we do a mechanical ventilation course as part of that, which I'll talk about. So we've been doing that for over a decade now. But so a lot of my colleagues were started reaching out during COVID from across the country, knowing my interest in mechanical ventilation. And then a lot of people were deployed to ICUs that hadn't been in some time, or they were just overwhelmed with the volume and they hadn't seen this much patient ventilator asynchrony. And so I would get these sort of texts, and these are images from text messages I would get during the pandemic. And so for those of you who don't know, the image on the left is a pressure time and a flow time curve. The image on the right is a pressure time, flow time, and volume time curve. And I've gotten permission to share these. These are some of the most famous critical care physicians in the world who are sending me these and asking what to do. So again, we have to think about this and how we train. These are things that I think as a society in critical care, we can say we haven't trained mechanical ventilation well. So it was a real wake-up call, I think, to lots of leaders in our field that, first of all, management of ARDS, a lot more interest. You see much more prone positioning in ARDS now, which I think has been one positive of the many negatives of the pandemic, but also understanding patient ventilator asynchrony and how we have to do a better job training our trainees. Because when we realize, again, lots of experts, whoever trained them didn't do a very good job. And so the challenging thing is to get data on this, because no faculty wants to be studied how well they do in skills, right? So there's never a paper on this. But there are now two. Our group did one recently, but Colombo in Italy did one. And so this was an Italian study in 2011, and they looked at 10 experts, at least 3 years as an ICU attending versus residents. And they had, waveforms like I showed you. They had a quiz of 43 pressure time and flow time tracings to identify asynchronies. And so the good news is the attendings did better than the residents, 33% to 16%. The bad news is 33% is not very good. So I think the take-home point is that, they did better, but obviously that can be optimized. And then so one of my mentees, Roxy Amaramati, who's now going to join us on faculty at the University of Maryland, she did a study with us. So we've been doing this course, as I mentioned before. So we'll have faculty from across the country say, I didn't learn this. Can we come to DC and audit your course? And we said, yeah, you can, but you have to take. And so this is how we collected data to see, okay, it's been 15 years since the Colombo study. Maybe we've improved in fellowship level critical care training, and we've gotten better at teaching and learning mechanical ventilation. So the answer to that question is no. So sadly. So our exam is the 5 most common life-threatening asynchronies. And what is it and how do you manage it? And each of the 5 is rated for 20 points. So it's a 0 to 100 exam. And Roxy was the first author. This was the abstract just got accepted for publication. And you can see the attending score was 24 out of 100. And again, depending on your priors, the fellow score was 17. The p-value is 0.0502. So you can decide if you think that's the attendees did better or not. And then you can see on the right side here, the figure of the deciles of scores for attendings and fellows. So again, I think you see we have work to do on this foundational skill in critical care. And we're talking about, as a community across the world, we have to work on this. So again, I want to think about use cases where we're not doing that well, and can AI help us? Because there's lots of risks with AI. So I think we're in a similar place to that Colombo study in 2011. So we started thinking about, okay, we have a group, we have people with a computer science background as part of our team, and we wanted to say, all right, one key thing, we don't assess learners enough, as I mentioned before. So how do we know where they're not doing well if we don't do more assessments? So I want to show you some of our early education research projects for AI and mechanical ventilation. So we said, okay, I'm not the biggest fan of multiple choice questions for highly complex concepts, but it's a place to start, right? Obviously, it's the most common question, whether you're in medical school or we're taking certification exams as faculty. So what we did is, I'm very skeptical. I'll give you all my priors. I'll lay it out on the table. I did not think for highly complex concepts, AI would do as well as we do in generating questions and being accurate. That is my bias. I said, all right, I'm going to be a researcher, and let's go study it. And we had a debate about it. And so we generated several multiple choice questions in highly technical fields: the equation of motion and Ohm's law, tau and autopeep, and then titration of ventilator parameters for oxygenation. So these aren't just kind of bread and butter, low-hanging fruit. And then we made questions, and we adhered to the National Board of Medical Examiners standards for generating MCQs. And then we asked ChatGPT, and we wanted to not do this like usual practice. So we didn't give any sort of information to focus on. We said, ChatGPT, make questions according to NBME standards. What's interesting about our study, so we've developed a national network now of experts in mechanical ventilation who teach it. So we didn't ask learners. We asked these experts to grade all the questions and then to tell you, can you predict if this is a human-generated question or an AI question? And so this paper was recently accepted. It's in press now in CHEST. And so you can see we studied non-inferiority, and we used a non-inferiority threshold of 5% for all these domains. Does the question align with the learning objectives? Is the correct answer indisputably correct? Is the stem of the MCQ clearly written? Are the incorrect choices plausible? And is this difficulty level appropriate for a graduating critical care fellow? And then there's a summative score. And you can see the left column are the AI-generated questions, and the right column are human expert-generated questions. And in every single domain, I ate the crow. The AI-generated questions were non-inferior. They're basically the same. And then again, we're asking experts who know this field. Tell me if this question was generated by us or it was generated by AI. And so you can see here, the AI-generated questions, the survey respondents thought they were AI 55% of the time. And then respondents thought the human-generated questions were AI 52% of the time. And that was a P of 0.32. So they couldn't tell. Again, experts in teaching mechanical ventilation. So I was genuinely surprised how well AI performed in the eyes of experts with no sort of control on the content. It just went to the World Wide Web. And so what I've learned from this, I have started to generate questions, because learners always want more questions, and ask AI to do it. I vet everything personally. And at Maryland, we're considering a research project of, students are always asking for more questions as they prepare for shelf exams and so forth. And should we develop a process and study it? So I think this is a very interesting area, and I think that's why it was recently published. So pretty interesting. But again, I think there are so many use cases for this across medicine. And what I'll tell you is, even if we're not using it as faculty, the students are already. So now I want to talk about something that's kind of an area of our group's passion and interest is deliberate practice, right? Training for expertise. Has anyone read this book, Outliers? Yeah, so a really popular book, really well written. Malcolm Gladwell's a brilliant writer. And he followed experts in multiple fields, such as music, sports, and computing. The common thread there between these experts is that they perform 10,000 hours of practice to develop that expertise, and that's what they need. And so it's funny, deliberate practice has become a mainstream phenomenon. Now everyone enrolls our children in things earlier and earlier so they can get their 10,000 hours and become experts, right? but it's a real oversimplification. And so I'd really encourage you to read actually Anders Ericsson's work, who Gladwell's work is simplified and based on. And Dr. Ericsson wrote this book, Peak, and he actually gives lots of examples from medicine about common errors and a lack of expertise. But his work is about deliberate practice. And so the point is, what is deliberate practice? And he outlines several elements. It must be purposeful, specific goals, requiring feedback, getting out of one's comfort zone, like I talked about earlier, right? And you need a teacher with experience in helping individuals achieve high levels of performance. And that teacher has to have rigorous assessment tools that can measure performance so they can provide feedback. So naive practice, just going out, doing your 10,000 hours of your sport or your music or, computer science, whatever it might be. Deliberate practice is hard because it's not just you doing the work. You really need coaching and feedback. And so our group, we been doing this course for a long time, and we said we really need to study this, and we keep iterating it. And so, as we said, now we have all the fellows who are starting fellowship. And, as we've seen over time, the exposures in residency have changed. And so people come with very different baselines of their understanding of critical care. And so in our group, we do very active learning. We do 4 days in the summer, and then we do in the summer education block and 2 days in the winter, where we do a lot of writing on whiteboards, calling on people, doing small group sessions and simulations. Now we've started to build this program out nationally. There's at UVA on the left and at Pittsburgh on the right. And so, again, we're very proud collaborators with Dan and the group at Georgetown here as well. And so we do this. And there's a picture of Bert Lee, who's been a mentor and a close collaborator of mine. He has kind of he's developed the program and been the driving force, and several of us have helped him iterate it over the years. But he said, you give the bolus, but you need the drip. Right. And so you can just do this for 4 days, and then you can do it for 2 days, but then you go away, expertise will decay. And we've published several papers, and I won't show you that in the interest of time, about the learning curve there and decay. And so what we set out to do is develop a preceptorial program for fellows. And now this has become also a nationwide program where it's based on the Oxford model, where the student would teach the instructor back then in a pub. And here we have some examples where some of us were in a pub in Bethesda for a happy hour teaching. And the people the waiter looked as funny, but it was okay. Or you could do it in a coffee shop or on Zoom now. But the trainee has to teach the teacher, and to advance to the next chapter and the more advanced concept, you have to pass these. And we schedule these for 90 minutes. And if the student's not prepared, it's a long 90 minutes of us just staring at each other, right? So that is the expectation to truly develop expertise. And so, as I said, you cannot move on to the next topic unless you demonstrate mastery of the current topic. Okay, and so there are no surprises here. We put all this in a shared drive. There are the pre-reading articles that must be read. Here are the cases we want you to teach us. Here are the concepts that you need to teach us. And here's a checklist. You need to do all these things. And if you do them correctly, you'll advance to the next chapter. So it's not a surprise pop quiz. The expectations are laid out. And so one of our great faculty members, recently on faculty at Maryland, Mike Keller, is the first author of our publication about this, where we followed learning curves. And what's interesting is you look at the left, the scores at the beginning of fellowship were 20 out of 100, not too different from the scores I showed you from prior papers. And then you can see 6 months later, the green and the red curves are both at about 80%. That's after our winter course. But then when the group in red had no further teaching, they just learned at the bedside, worked with whoever they did, and were supposed to do the learning on their own. You can see over the next 6 months, their scores decreased to less than 50. And by the end of fellowship, 3 years later, they're down to less than 40%. So getting pretty close to what we saw in that Colombo paper. But the people who did that year-long preceptorial program, you see their score was 90 at the end of 1 year, and they only decayed to 78% at the end of fellowship when they had no further training in the next 2 years. So for some foundational concepts, right, you need more time. We need to devote more time, and we need to develop expertise. And I've been on milestone panels for ACGME. A lot of it, frankly, is not very useful to make hundreds of milestones that someone needs to meet. We need to train people in the foundational skills in our subspecialty or subspecialty, and we need to be very intentional. And no matter how painful it is, we have to do it. And we know what we need to do in our use case here in mechanical ventilation. And again, that p-value is 0.001. But then we also, when we give talks and we meet with people across the country, we ask their fellows to take our test. So the fellows who are getting an average of 6 hours of teaching of mechanical ventilation, they're scoring 20. So that's the standard practice. And that's at a median of 2 years after the beginning of training. So we're still having the same practice. And so the problem's predictable, right? We need a deliberate practice approach. This is a lot of work for the learner and the educator. So almost 100 hours of time for the average learner to do this in addition to all your clinical responsibilities. And then, in academic medicine, staff are more and more compressed for time to take these 90-minute sessions out of their day. And then we get into a very practical problem. When you do that intersection of that Venn diagram with subject matter experts who are excellent teachers who also have the time to do this, it's very, very small. And so how do we scale this education if we need to do it across the entire country and we have a path that works? And that's where something like a good AI solution would be very helpful. So I'm really excited to talk to you about our next project. And we're in the process of working on AI to try to scale elements of deliberate practice in mechanical ventilation. And so at top is one of our senior fellows, my mentee. She's amazing, Preet Alawalia. And we're partnering with Laura Turner, you see below Preet in the middle, at University of Cincinnati, and her team, who developed an application called 2 Sigma that really is a clinical reasoning AI application that walks through clinical cases with learners and provides personalized feedback. And this has traditionally been text-based student cases, but we're working on them on a higher level, incorporating imaging and doing it at a fellow level, which is their first use case for that. And just showing you some of the details, this is a multi-agent system, right? You have a patient agent giving the patient history, a result agent giving x-rays, EKGs, labs, an exam agent for elements of the physical exam. And then we build a rubric in for an evaluation when you give your leading diagnosis, your differential diagnosis, how quickly you went through the case, but how thoroughly you did. And so I'm going to show you a sped up 2-minute clip in the interest of time to walk through this. And I'll pause at certain spots to walk through some of the details. This is a student case because our case is still in process. We keep breaking the AI and we have to keep fixing it. So you'll see it's fast, but this is a patient with dyspnea on exertion for the last few weeks. At the bottom of the screen, the student is writing in their prompts and they're asking for portions of the history. Do you have a cough? Do you have shortness of breath? Does it happen when you exert yourself? And the agent in the white there is giving answers to the questions. They're only dyspneic on exertion. They do have some lower extremity swelling, really mostly when they're climbing stairs. Now I want to do a physical exam. What part of the physical would you like to perform? And so the student will ask all these questions. They ask about thyroid nodules. There are no thyroid nodules. But then they skipped over. They didn't do the rest of the exam looking for JVD, peripheral edema. So then they asked for an X-ray and an EKG. And they show an X-ray and an EKG. And at this point, they see that they're getting off track. So this one builds in an agent for a supervisor to come in and help. And so you can see here, they're asking for labs. So they'll build in the labs here. And the labs will come back. And they're worried that the student is kind of glitching. So in green, the supervisor, what can I do to help? And they say, okay, help me interpret this chest X-ray. I don't see fluid in the fissure. And so the agent isn't supposed to give them the answers, but keep prompting them to dig deeper. But they don't keep doing it too much because, again, they want to assess the student. And so talking about pulmonary edema, that's a good observation. So then they have to eventually put in their leading diagnosis and their differential diagnosis. And then the case is submitted successfully in orange. And you can see all the feedback walking through. Did you give enough history? Did you give enough physical exam? What diagnostic tests did you order? And this is all an AI-based multi-agent system, like I mentioned. And then scoring you on what are the key learning points from this case that you need to know? And what is your overall performance? And so this has been, again, done at a more basic 3rd and 4th year student level. we are doing this at a fellow level and trying to build high-level cases with some of the waveforms that I've shown you that we get on a very frequent basis. So our upcoming goals are to build out our adjudicated ventilator waveform database, to build training sets for assessment, to link these assessment answers to self-directed learning resources based on what the student gets wrong or right, and use natural language processing to determine best practices for learning concepts. When we do these one-on-one sessions, we have 90 trainees and 35 preceptors across the country. We lead the program, but we don't know what's happening in individual sessions. But if we could record the sessions and see where the common places people get stuck and what the best educators are doing them over the hump, that's impossible for us to do, but an AI tool can do that. And so we're thinking of submitting a Precision Med Ed grant for that. And so I've recently started, as Dan mentioned, at the University of Maryland, and part of my work is leading educational efforts, research efforts at the Institute for Health Computing, which is a really exciting collaboration between College Park, University of Maryland, the undergrad campus, and Baltimore, which is the medical campus. And so where I have the opportunity to collaborate with experts who are computer scientists, AI experts who've built foundational models. And we also are starting to collaborate with tech industry partners as well to get advanced access to some of their newest versions of Gemini and ChatGPT and so forth, and see if they can do more sophisticated things like drawing of waveforms and such. And so I just want to also, as I'm closing, highlight the reason we're able to do these projects and publish them is we built a critical care education research consortium, starting with our group in the DMV, and now it's become national. We have 40 fellowship programs at 24 academic centers, some of the top academic centers in the country, including Georgetown. So that's what really allows us to test this at a high level and do multi-center trials. And so, but I think, again, my interest is here, but there's so many things that the same model can be used. Teaching physiology, which is becoming a lost art. Ultrasound, we're trying to scale a program for all medical students to learn ultrasound. But again, that will decay. So you need to have a continuous learning cycle. Another thing that's very interesting, some colleagues at the University of Pittsburgh are going to lead a CCRC trial for serious illness conversations. We all have to have these conversations in hospitals, but we know there are programs like Vital Talk, which is a very popular one, where they have patient actors that are paid, but that's also very expensive. And how do you keep practicing? So he's doing a study of an AI agent based on Vital Talk, so you can have continuing practice conversations. So there's lots of opportunities here to use it. So again, I've spent a lot of time talking about some of the risks, but there are clear opportunities here. And then one other area that I haven't started in, but I'm interested in doing is procedural training. And this is Atul Gawande in the New Yorker, like in 2012, the famous endocrine surgeon. It was interesting. He went on vacation. And he said, I used to play tennis. I got a tennis lesson. And I immediately, with the tips I learned in the tennis lesson, I became a better tennis player. So I've been a surgeon, an endocrine surgeon, for now 8 years, and my performance has plateaued. Why can't I get coaching? So he reached out to a mentor who's a retired endocrine surgeon, Dr. Robert Osteen, to watch him in the OR. And he just sat on a stool with a yellow notepad and gave him feedback. And he noted several things. He noted there was issues with positioning. He was sometimes positioned in a way where his assistant couldn't see him well. The lighting was off, so he couldn't see so well. And then he was putting his elbow high in certain times, and he didn't understand his choice of instruments at certain times. And he said that one 20-minute discussion gave him more to consider and work on than I'd had in the past 5 years. So we, as faculty, we don't coach each other. We don't get that support. We don't have that kind of culture of saying, hey, let's all keep getting better and practicing and giving each other feedback. It's a real challenge. And then, so I was very excited about this paper, but it's been over 10 years ago and it hasn't been scaled. But there's a paper in the New England Journal from a group at Michigan. They looked at scoring of laparoscopic bariatric surgery. And they studied 10 surgeons, and the scorers were blinded to the surgeons, who they were, how many years of experience they had. And they scored them based on 5 domains and then provided a global score. And you could see the difference here. I'm going to show the clip. Here is a master surgeon, and you can note there are very fluid movements. The instrument changes are occurring with minimal disruption. And now we're going to see a surgeon who is a more lower rated surgeon, we'll call him. And you can see that the tissue is being handled more roughly. And then you can see over time, you're going to start to see small injuries to the bowel wall.
Compared to the first video.
Okay. And there is audio there in the background, but that's basically what they're saying. You're starting to see these injuries here. And so this got into the New England Journal because the impressive part of this paper is that master surgeons they identified just by watching video clips and scoring them, they had, you can see complication rate, higher scores. You just look at that straight line down, had less patient complication, infection, obstruction, length of stay, and death. Okay. So, and the surgical scores were not related to years of practice, right? So there was an objective way to assess, and then but that's really not gone anywhere. And so I think that that's an area, excuse me, that we haven't seen scaled implementation. And so I think one of the things that many have talked about, I haven't really seen much published on this, is implementation at scale. You can imagine building procedural databases, and AI could comb through hours and hours of recorded content, identify the most relevant clips based on your queries, and then give those to evaluators and supervisors and mentors, excuse me, to review. And AI then could help the educators provide specific examples of best practices and then provide relevant resources to learners who are struggling in specific domains. We have these ideas, but we've just never been able to scale them. So again, there's an opportunity here, even despite all the risks I was scaring you with at the beginning of the talk. So in conclusion, I'll say over-reliance on AI before you develop may prevent development and cause decay of expertise. And there's an opportunity for AI to scale precision medical education, which is really our holy grail. But we really need to research the best approaches to AI integration and the unintended consequences in medical training. And I just acknowledge the members of our team I've shouted out before. It's just really been a fun community of people across the country as we built, and everything that when we do these projects, it's really collaboration.